So it's my pleasure to introduce Dr. Christina Surawicz to speak at Medicine Grand Rounds this morning. Dr. Surawicz is a professor of medicine in the Division of Gastroenterology and Associate Dean of Faculty Development for the UW School of Medicine. Dr. Surawicz, she's also served as a section chief of gastroenterology at Harborview Medical Center for 20 years. Dr. Surawicz earned her medical degree from the University of Kentucky and then completed her house staff training and gastroenterology fellowship here at the University of Washington. During her time on faculty, she has been a model of excellence, extending from clinical medicine, medical education of house staff and fellows, mentoring of junior faculty, and clinical research. She is celebrated as an authority in the role of biopsy in diagnosing colitis, as well as several other endoscopic techniques, but is probably best known for being a world leader in the treatment and management of recurrent Clostridium difficile infection, specifically for the use of fecal microbiota transplant and probiotics. She has previously served as president of the American College of Gastroenterology. Please join me in welcoming Dr. Surawicz as she presents strategies to break the glass ceiling and treat physician burnout.
Thank you very much. I'm really pleased to be here to talk about two topics that seem like they're different, but actually might be somewhat related. So why did I choose these two topics? I'm following up on the grand rounds that Lauren Brown gave last year as chief resident, and she's now on our faculty. Her talk was on women in academic medicine, a rising tide lifts all boats. And I'm going to focus on why there are still so few women in leadership positions in academic medicine. I'm also following up on a grand rounds, and you can watch Lauren's grand rounds, which I recommend highly, on YouTube. I'm also following up on Lottie Derby's grand rounds. She is an authority with Tate Schoenfeld on burnout, and she gave a grand rounds on physician burnout, prevalence drivers, consequences, and strategies to mitigate risk. And unfortunately, that was not on YouTube, but she has published widely in this area, so her papers are a good reference. And so I'm going to focus on that part of my talk, not so much on the why, but on the what to do about it. So going back to match day in 1973, when I opened my envelope in Lexington, Kentucky, I saw that I was going to end up in Seattle at the University of Washington. Like many people at that time, I thought Seattle was going to be a lot closer to San Francisco. The university, this is the best, the computer match is the best thing a computer ever did for me. I've been incredibly fortunate here to be in the Department of Medicine, to have my clinical work at Harborview, to be in the Gastroenterology division, and to work in faculty development. So here is my internship class, and we're standing on the steps at Hogness, which would probably look the same as they did back then in the spring of '74. This is me, this is Dr. Petersdorf, and this is Dr. Turk. And Dr. Turk, as you know, is still, has until recently been still active in the department. So at this time, about 10% of medical students were women, and in my 22-person internship residency group, I was the one woman. Morgan Jackson was the one Black African-American man, and there was one Asian man as well. I want you to notice that we wore uniforms, and I had to wear a skirt. I really wanted to have pants like the guys had, but I had to be stuck with the skirts. So what about nowadays? So this is national data looking at all medical schools across the country, and 46% of medical school graduates are women. That may actually even be higher in a few years. Internal medicine residents, 43% are women. In subspecialties, a little bit lower, 37%. And let's focus, what I'm going to focus the rest of this part on is really faculty, medical school faculty. So 39% of medical school faculty overall are women, and it's lower in the basic sciences, 34% compared to in the clinical departments. So I just made a little diagram of what this actually looks like. So for all faculty, 39% are women. But if we look at the ranks, starting as assistant professor, going to associate, and then to full professor, we can see that the numbers drop off. The percent of women is 42% at the beginning rank, then it drops to about 35% to the associate professor rank, but then a pretty major drop to 21% at the professor rate. So just graphically, you can see almost equal, not quite equal for the assistant professor, dropping at the associate professor, and only 21% at the professor level. So what about UW School of Medicine? We actually look pretty good, or a little bit better than nationally, because we have 51, so more than half of our assistant professors are women. We're doing about the same at the associate professor level, and we're doing a little bit better at the professor level. So what about the Department of Medicine? We pretty much mirror the School of Medicine as well. Overall, we're a little bit lower at the assistant professor level, but remember, some departments are very high, like OBGYN, in numbers of women. So this is just an overall. We're better than the School of Medicine at the associate professor level, and we're the same as nationally at the professor level, a little bit lower than the school. And if we look at the breakdown of our faculty between regular faculty, so that would be clinician teachers and physician scientists, compared to clinical faculty, so that would be what we call full-time clinical faculty, although not all clinical faculty work full-time. You can see that there's a little bit higher number of women here on the clinical faculty at both the assistant and the associate professor level, and fewer at the professor level. But let's focus now, in addition to professors, what about leadership? So nationally, about 15% of department chairs across the country are women, and this has not changed since 2009. And about 14% are deans. So pretty low numbers, basically. So what about the School of Medicine? So here, that 15% nationally, but in the School of Medicine, we actually look a lot better than nationally, because 11 chairs out of 31 are women. So we actually are doing better there. Let's look at the leadership. Obviously, our dean and our department chair are both men, but if we look at the leadership teams that they have in the dean's office, we can see that over half of the vice and associate deans are women, 52%, and 38% of the assistant deans are women. And in the Department of Medicine, we can see that one of 3 vice chairs is a woman. Dr. Brody is here. We see that 38% of division heads are women, 34% of section heads, and 29% of endowed chairs and professorships. So we're doing really pretty well. And if we look here, and I do want to shout out to Amy Fields, who provided this data for me. I'm very grateful to her for that. You can see that there were no division heads until 2006, when there was one, and there's a gradual increase in division heads to a high last year of 2017. And while it dropped, it actually dropped for a good reason, because Sue Stern went from being the emergency room division head to being an emergency room department chair. So these gender differences in academic medicine are well documented and also have been studied. This Phyllis Carr did a study of 24 medical schools, and we were actually one of the medical schools in this study. And then they did a 17-year follow-up and found that women were less likely to stay in academic medicine and were less likely to have leadership roles, 21% for men and 10% for women. So we're doing pretty well compared to the national numbers, but could we do even better? So what I want to focus on is, what are the reasons why women may lag in advancement? So is it the glass ceiling? So the glass ceiling is a term that was first used by Catherine Lawrence, a Hewlett-Packard executive, and that's women can advance to a certain level but can't go higher because there's an invisible barrier, meaning that glass ceiling. Or is it the leaky pipeline? Is it that women drop out at each step of the career ladder? So I think that it's probably both. And this is how I'm going to talk about it. I've thought a lot about what are the things that contribute to glass ceiling and leaky pipeline, and you might not agree with where I have put those, but this is what I'm going to talk about. That I think the glass ceiling issues can be broken down into things about institutional culture. And so in that, I'm going to talk about equity, work-life integration, and barriers, and also bias, conscious and implicit bias. And then leaky pipeline, I think, is due to lack of mentoring and lack of leadership development. So let's talk first about institutional culture. So one measure of that would be salary equity. And here at the School of Medicine, I think we're doing a very good job of studying salaries. Starting in 2002, when I began to chair the Women's Committee, the dean asked us to do a salary equity study, to repeat one that had been done previously, dividing faculty into 4 different groups. And when we did that study, we found there were 3 departments that looked like there were salary inequities, and we had data prepared that went over salary, gender, degree, years in rank, and rank. And when we met with those departments and administrators, there were some inequities in 2 of the departments, and in a third there were some explanations. And we realized that this was a much better way to look at salaries, and we recommended to the dean that we do all of the departments over a 2-year period, which we did. There was no systematic gender bias, and this process has been going on since that time until last month when I did my last meeting. It's a 3-person team. I have been the person consistent since 2002, and it's been usually a controller or finance person in the dean's office and a lawyer from the dean's office. So it's a very time-consuming method. I'm not saying that our salaries are where they should be. We want them to be at the 50th percentile for AAMC, and they're not for many departments or divisions. And there still are some concerns about compression where new faculty are coming in at higher rates than senior faculty. But being aware of those and addressing those, I think we're doing well on salary equity. And so now we look at every department every 3 years unless there's a new chair. But I don't know how we're doing in terms of equity. I don't know how we're doing in terms of space like lab space and office space or administrative clinical research. But at MIT, and I was delighted to find this pink measuring tape, Dr. Nancy Hopkins was a scientist there, and when she was denied a request to get more lab space for her zebrafish experiments, she actually took a tape measure, went around measuring lab space, and found that the men had less lab space than she did. Even junior men had less lab space. And so other women joined her in going around and measuring, and this has led to major culture change at MIT. What about promotions? Nationally, women lag behind numbers in promotions to associate professor. Why is this? And I think the one reason that we all know about is the academic clock and the biological clock may be ticking at the same time. So traditionally, there's 6 years to be promoted from assistant to associate professor, and it is up or out. If you don't get promoted, you do leave the institution. That 6 years can be extended for a variety of reasons, for having children, being ill, or having problems with your research. That's when you are in your 30s, and it's a necessary time for academic productivity. But that's the same time that you may want to be starting a family, or you may want to do something else that's important, like climbing Mount Everest. So research funding challenges are huge. This is a national crisis. The average age of getting the first NIH R01 grant is 42 to 45 years old, despite the NIH's efforts to increase early career awards. And the challenges of getting research funding definitely affect women more than men in terms of pregnancy and maybe with other home responsibilities. But there are solutions to that. I think making sure that that promotion policies are fair and reviewed with faculty input, getting promoted on the basis of the work that you were hired to do, which is something that Paul Ramsey has stated over and over is his view, having annual reviews that are timely and honest and well documented, and just to junior faculty, if you're being asked to do an administrative role, make sure that it's not going to harm your chances for promotion. Other solutions are working part-time and flexible work schedules. Slowing the clock, as I mentioned, you can extend the promotions clock 1 year per child. And I wonder if it's time to just get rid of that academic clock. So culture, what about work-life integration, which is now the term in terms of work-life balance? So are we family friendly? Do we have 7 a.m. meetings or 6 p.m. meetings? The Department of Pediatrics has quarterly dinner meetings, and they have on-site daycare, and their faculty tell me that their kids love going to these daycares. They love going to the departmental meetings. That's obviously something that children can do easily that other institutions can't do. So we have a very good maternity leave policy with 3 months of paid leave for birth mothers, but paternity leave can be quite variable and isn't really well defined in some departments. And there is no paid leave for adoptive parents. And this is something that is finally being discussed by the Faculty Senate, but those wheels move very slowly. But this is something I think that the university should adopt. We should make sure that we don't have bias against women when they take that full 3-month leave. I know some women have felt so guilty that they have returned to work before that 3 months. And then the Women's Committee, we put together a family-friendly packet on the faculty development website to go over and put in one place all the information you might need about what are the leave policies, the promotion policies, childcare resources, and so on. So other solutions for work-life integration are having a place for sick child drop-in. There used to be one at Virginia Mason. A faculty member told me that her son liked it so much that he actually feigned being ill when he wasn't ill. That doesn't exist anymore, but there is a different sick child drop-in option available that you can see on the Upper Campus website, but you should sign up for that ahead of time. Nanny share programs, we all need to have backups for emergencies, whether it's a childcare emergency or a health emergency. And then daycare. Here's some place where I think we as a university are falling short. So Dr. Anna Marie Kasi was appointed UW president in 2015, the first woman president of the university, and the Portage Bay Daycare opened in January of 2017. That was the first new daycare in 17 years. I don't think it's a coincidence that we have a woman president and we finally have a new daycare center. It still falls very, very short of what we're needed. They say you should sign up for that daycare as soon as you know that you might be having or adopting a child. And there is a child care access initiative, but this is a place where I think the university does fall short. And then the third thing about culture is, do we identify barriers? So when Doug Wood took over as chair of the Department of Surgery, he asked Chris Calhoun and colleagues to have a surgery women's council. So they did a survey of all the residents and the faculty to determine barriers to success in academic surgery. Note that they had a fairly small survey instrument of 37 items because they figured people wouldn't fill something out. It was taken from a 122 survey, and so it was decreased to that. But also notice their response rate, 74% for residents and 66% for faculty. For the faculty, they did an online survey, but the residents didn't want to do an online survey because they had concerns about privacy, so they were given a paper form to fill out, and they were given the forms when they were taking their in-service exams. So I think they got a pretty good response rate. So what did they find? More women than men perceived that they were treated differently based on gender, that there were negative comments based on gender, and they felt that gender would be a barrier to career success. No men reported feeling that gender was a barrier to career success. Interestingly, the residents were more positive about the role of gender in career success than the faculty were. So that's good. So career barriers that were seen more for women than for men was a lack of role models and mentors, the desire to have children and childcare concerns, which gets us back to that daycare, and attitudes about gender. So identifying the barriers allows this department to address the concerns that they have identified. So we have a Department of Medicine Diversity Committee formed in 2014. The chair is Dr. Rudy Rodriguez, and the department are planning a survey next month as well. And I think finding data will really help to identify barriers. As you know, if you read your email 2 days ago, Dr. Bessie Young is now the department's associate chair for diversity and inclusion, and we're just thrilled to have this new position as well. So let's go to the other bias, unconscious and implicit bias. This is the other thing that I think contributes to culture, to the institutional culture. So there's obvious conscious bias that we see. Examples of this are the ideas that leadership roles traditionally are held by men, that men take charge and women take care. Those are pretty conscious biases. There's also a conscious bias that male traits are a better leadership fit. And this obviously is wrong as well, the male traits of dominance, self-reliance, and confidence. So these are very clear improper biases. But what about implicit or unconscious bias? These are biases that we're unaware of. They happen without our control. They are measurable. You can go to the Project Implicit website at Harvard, and you can sign up and you can take your own, you can measure your own bias for a variety of different things, for race, for gender, for age. It's very sobering. It's also very accurate. So Dr. Tony Greenwald and Dr. Banerjee, they together developed the implicit association test. And Dr. Greenwald is a professor here on Upper Campus, and I asked him to do a workshop on bias a couple of years ago, which was great. This book which they wrote is very, very readable, and I really recommend that you all read it. He said that when they first took the implicit association test and saw their own biases, they were so sure that there was something wrong with the test that they took it several more times, and then they realized that the test was actually very accurate and identified. So we have these biases. We can't change the biases, but we can put in place solutions to mitigate the biases. So examples of implicit bias are that in this paper, men and women scientists were given resumes for a student applying for a lab position. And in one, the resumes were identical, but in one of the resume had a woman's name and the other that had a man's name. And the scientists, both the men and the women, ranked the woman lower, would give the man higher marks, a higher salary, but they did like the woman more. So implicit bias is measurable and ingrained, and we can't change it, so we have to put in systems to mitigate it. So in the 1970s, only 5 or 10% of musicians, symphony musicians, and leading orchestras were women. They implemented blind auditions, and the number of women rose to 35%. They also had to be very careful not to be able to identify a woman by what her shoes might sound like as she entered the stage, which is why I have the picture of the high heels here. So it has to be truly blind. This is an article that looked at implicit bias in a training program. So this was emergency medicine training programs. They looked at 33,000 evaluations from 8 different ER training programs, and they looked at the rate of attaining milestones for men and women. And at the PGY1 level, there was no difference between men and women. But by PGY3, the women were behind by 3 months. And this was based on evaluations by both men and women evaluators. So why is this? We don't know for sure, but one of the theories from the paper is that there's an expectation of leadership by the R3 year, and that leadership traits of assertiveness and independence and male traits may have then prompted the better evaluations for the men than the women. But there's an example of the kind of research and education that we really need. So implicit bias can be subtle or it can be obvious. Women physicians are more likely to be addressed by their first name than doctor. How many teaching awards have been given to men and women? How many women are on the program of the next meeting that you're attending? I have always, and I can't stop myself when I look at a meeting I'm attending, count up the number of women and underrepresented minorities. This study last year looked at grand round speakers. How many women were grand round speakers? So they analyzed calendars from 79 institutions. The percent of women was highest, as you might expect, for OBGYN, where 60% of the grand round speakers were women, and lowest for radiology, interestingly, at 20%. And for internal medicine, it was about 28%. So I looked at our calendar, and so last year, 11 of 39, or 28% of speakers were women, and then this year through today, 39% are women. I don't know what's coming up the next few months. So you may have seen this hashtag, what a doctor looks like. Dr. Tamika Cross last year was on a Delta flight when the flight attendants asked for medical assistance. And she posted this on Facebook. She said, I raised my hand to grab her attention. She said to me, oh no, sweetie, put your hand down. We are looking for actual physicians or nurses or some type of medical personnel. We don't have time to talk to you. A white man then got up and assisted. She was eventually able to assist in the medical emergency, but the white man's credentials were not questioned at all. So what do we do about this? We can't change our biases, so we have to put in solutions to mitigate the effect of the bias. So measuring it, monitoring it, acknowledging it, and we have implicit training modules here at the University of Washington that Dr. Janice Sabin has been involved in, and those are now mandatory for everyone who teaches medical students. They're also mandatory for everyone who's on the search committee. And the modules, we only have to take 2 of 4, but I've taken all 4. They're actually really quite good. In addition, in search committees, we need to make sure that there's diversity among the committee members, and there are also a lot of good resources on the university's website. So that's what I want to say. Those are the things I think contribute to that glass ceiling, the institutional culture and bias. But why is the pipeline leaky? Because it is clearly pipeline as well. It's not just that it's clearly a leaky pipeline problem as well. So I think I break this down into lack of mentoring and lack of leadership development. So a systematic review of mentoring in academic medicine reported that mentorship it's like apple pie. Of course, it's a good thing to be, to mentor, to have a mentor. And in this study, they found it was helpful for personal development, for career guidance, career choice, research productivity, and success. So my mentor was Dr. Cy Rubin, was one of the main reasons that I went into gastroenterology, and he recognized in me a talent for histopathology that I didn't even know that I had. I had hated pathology as a medical student, but he was right, and I did enjoy it and became good at it. So mentoring can be in a variety of different roles. Peer mentoring is really helpful. The National Science Foundation had grants, the advanced grants, and the School of Engineering had one as well. And after a number of years, the junior faculty said that the peer mentoring was actually the most valuable for them. And I want to say, just one of my themes across is that peer support and peers, we are our best advocates for one another. You need to have multiple mentors. When I had twins, I certainly didn't look to the men in my division for how I was going to combine that with having my family and work. You can have a long-distance mentor. I've had a couple of long-distance mentors as well that I met. You need to have personal, as I mentioned, and professional mentors. And mentoring can be formal and informal. And many people who do a lot of mentoring don't even know that they're considered mentors. In the Department of Pediatrics a number of years ago, they asked the faculty to put down who were their mentors, and several mentors were surprised to realize that they were being considered as mentors. So. Other solutions, we all know about the old boys club, and they can go golfing and happy hour and all of those things, but we need to have old girls clubs as well, and especially young girls clubs. And then finally, there's the notion of sponsorship, and that's someone who advances you, not just advises you with opportunities and introductions. So we do, it's important to recognize and reward mentoring. We have a UW School of Medicine Award for Excellence in Mentoring Women Faculty. The first awardee was a Department of Medicine member, Dr. Nora Desis, in 2002. Sometimes we split the award because the nominees are so excellent we can't choose between the two. But if you look at the 26 awardees through this year, 10 are from the Department of Medicine, which is more than from any other department, from divisions of oncology, general internal medicine, infectious disease, pulmonary, dermatology, and cardiology. So I think as a department, we're really doing quite well. It's a wonderful process looking at the nomination packets, because we realize what a good mentoring culture we do have. And in our department, we have a mentoring committee that's chaired by Dr. Ellen Schur. They have conducted a faculty survey and identified areas for improvement. They have standardized discussions with junior faculty at the appointment level so that junior faculty know what is expected of them so they can succeed. They promote the use of an independent development plan form so that faculty can say what they are doing, what they'd like to do, what they need to do to get to the next level. And they've established a departmental mentoring award for both both physician scientists and clinician teachers. What about leadership development? I think better leadership development would also help to patch that leaky pipeline. So Bruce Avolio is a business professor on Upper Campus, and I came across this article that he was one of the co-authors on, and it's analyzing what are the leadership behaviors that actually improve performance in an organization. So I'm going to read through those, and then I'm going to tell you which ones are traditionally associated with women, which one do women use more, and which ones do men use more. But you could think about it as I'm reading this to you. So people development, expectations and rewards, role modeling, inspiration, participative decision-making, intellectual stimulation, efficient communication, individualistic decision-making, control, and corrective action. So men and women were the same in intellectual stimulation and efficient communication. Men were more likely to use control and corrective action and individualistic decision-making, and women were more likely to be using people development, expectations, rewards, role modeling, inspiration, and that decision-making. So it's interesting. So there's a myth and a truth. So sometimes I hear people say, women are just too smart to want to be a chair or a division chief or a dean. Well, that's obviously not true. The other thing is, however, what is true is that women are more likely than men to say they're not prepared for a new challenge and thus to pass on those opportunities. This is highlighted in Sheryl Sandberg's book, Lean In, but I've seen that as well. Women are saying, I'm not ready for that, I need to do more, whereas men are saying, sure, I'm ready for that, I'll do it. So I think that for my advice for women is to go for it and overcome the imposter syndrome. I had the imposter syndrome. I think I had it until about 5 years ago. That's the imposter syndrome is, they're going to figure out I'm not that smart and that I really don't deserve to be here. I definitely had it in my internship class, not only as the only woman, but the one from the University of Kentucky, when 4 of the guys were from Harvard. I definitely had imposter syndrome as a House officer, but we have to overcome that. And it's not just women that have imposter syndrome, men have it as well. So what are some solutions? So solutions would be women in medicine and science programs, providing mentoring and coaching and leadership opportunities, and supporting young men faculty as well. And as Dr. Brown mentioned in her grand rounds, a rising tide floats all boats. So some of the things that I have found helpful in leadership development myself are learning about myself, self-awareness and reflection. There are a variety of different tools that you can use. A book called Now Discover Your Strengths by Buckingham, based on Gallup poll data. And this, you take a test after you read the book and it gives you your top 5 strengths. So my top 2 are harmony and fairness. And you can see right away that those are a huge class. Right? Because you want things to be fair, you're going to have to deal with conflict. So I learned from dear Dr. Emily Wong that you have to embrace conflict, because without conflict, there's no change. So I had to learn to do that. You also have to learn about other people's personality styles and communication styles and how to resolve conflict. And there are a variety of different books and tools that are helpful there. I learned a lot about about leadership development in my professional society, the American College of Gastroenterology, from being on committees and board of trustees and leadership. I also learned a little bit about watching what people do and also what people do that I didn't want to do. There are a lot of books that are great. Most of them are in the business literature. TED Talks have been amazing. And then take any course that is offered to you, take it. I went to the AAMC Mid-Career Program for Women, which was really excellent. So, to end this part of my talk, I think there are a lot of things that we can do to break the glass ceiling and to patch that leaky pipeline. So I'm moving on now to battling physician burnout. So there's an epidemic of burnout. There's so much literature on burnout, it's really kind of overwhelming. It's defined, very well defined, as 3 components: emotional and physical exhaustion, depersonalization, and a decreased sense of personal accomplishment and success. And I think in medicine, I think we're quite lucky that this is very low, that we really are very low on that, because we know that what we're doing is important and helps people. So I don't have any disclosures here, but I did survive burnout. So 3 years ago, I was asked, I didn't know anything about burnout really until 3 years ago, when I was asked to give a named lecture at the American College of Gastroenterology. And this topic was given to me, and I started to read the literature, and I realized I had been burned out. When I was a junior faculty, I had 3 little boys at home. I had a husband in full-time private practice. I had a house that was so messy that the maid brigade fired me. They said our house was too messy to clean. But those were not the reasons that I was burned out. I always felt completely supported at home. That was not why I was burned out. I was burned out because I felt I didn't have any control at work. And I was able to go to the section chief and make at Harborview and to make some changes, and I did survive that burnout. I would not be able to talk about burnout without the work of Dr. Tate Schoenefeld. He was a resident here, and he did the first study of burnout when he was a resident. His study was published, and they found that there was a definite correlation of burnout with perceived medical errors. His study also had an amazing response rate in the 70 to 80% and the highest in the internship group. He went on to be an oncologist at the Mayo Clinic and has been a leading researcher on burnout with amazing work that he's done with the American College of Surgeons, with cohorts at the Mayo Clinic, and so on, and has now taken a job as the Chief Wellness Officer, the first ever Chief Wellness Officer at Stanford. So on this graph here, they looked at what was the change in burnout over a 3-year period, 2011 to 2014. And all I want you to see here is that these blue bars, which are 2014, are all going in the wrong direction. They're all going higher. So the rates are highest for emergency medicine and lowest for pediatrics and radiation oncology. So overall burnout rate, 41%. For general internal medicine, 58%, and it's known to be very high in primary care, family medicine as well. And then for internal medicine specialties, 42%. So generally, the burnout rates are lower in academic medicine compared to private practice, so about 34%, so that's good for us. But if we think about academic medicine, John Kabat-Zinn, a leader in meditation, says academic medical centers are magnets for suffering, and then there are the patients. So Schoenefeld did a study of internal medicine faculty at the Mayo Clinic, and look again, 84% response rate. People are very interested in this topic and are very willing to share their experiences. 23% women, 90% married, and about 2/3 had school age or young children at home. And they found that the overall burnout rate was 34%. It was higher again for the generalists compared to the specialists. It was higher for women, it was higher for those younger than 55, and it was higher for those who worked longer hours a week, and more than 5 days a week. The multivariate analysis showed that spending less than 20% of time on what was most meaningful to you, no matter what it was, correlated with burnout. And that for most people it was teaching or patient care or research, and for a small number it was actually even administration. So this is very important, and a number of papers have been published and looking at why do we have this burnout. 80% is system factors, 20% is individual factors. And Dr. Christine Sinski is now a leadership role in the AMA, and she gave a grand rounds here on Joy in Medicine, showing that those people who were happiest in their jobs in medicine were going home at 6 o'clock and not charting after dinner because they had support staff in their clinics of 2 or 3 to 1 for their physicians, doing scribing, order entry, and so on. And leaders are finally paying attention because it costs a lot of money to replace burned out faculty who leave. It also burned out faculty more likely to have lower patient satisfaction scores and maybe not even do such a good job of being a physician. And also are recognizing that there has to be reform at national and state levels on what are the documentation requirements and so on. And Asinsky and colleagues are suggesting that this triple aim actually should be the quadruple aim, and clinician satisfaction should be there. And last month, the AMA published their charter on physician well-being. So now I want you to take the piece of paper in front of you and just see what your own risk of burnout is. This is only for you. I am not going to ask you to do a pair share. And I'm not going to ask anyone who scored, 5 or 6 Y or 0 or 1 Y. And again, this is from Lottie Derby and Tate Shanefeld's work. So a yes is a 1 and a no is a 0. And if you scored 3 or higher, then you are at significant risk of burnout. So let's talk about what to do about it. So we can look at the drivers of distress as workload, efficiency, flexibility and/or control, community at work, work-life integration, culture and values, and meaning in work. And I like to think about the solutions as the practice of medicine or external, and the practice of ourselves or internal. And I'm really going to focus on this second part, that 20%. But the way you can take that list and divide it is the practice of medicine are things like the workload, efficiency, flexibility, and community. And the practice of ourselves is the work-life integration, culture and values, and meaning in work. So the practice of medicine, this is not my focus today, but I do want to say a few things about it. This is the 80% that having a better electronic health record, this is the biggest driver of burnout, is the electronic medical record. But also having more support for clinical work. There are pilots having scribes in dermatology and ophthalmology here in our medical school. And there are randomized controlled trials of interventions that show that interventions do decrease burnout, especially when physicians have control over workflow and better communication with peers and staff. I want to say something about complications. A Seattle surgeon said many years ago that the day you stop feeling bad about your complications is the day you quit. As a gastroenterologist, I have had complications, I have made mistakes, and things have gone wrong. And I have remembered every single one of those, whereas I may forget good things that happened. The burnout and the burnout association with errors, I think it's both cause and effect. I think burned out physicians are more likely to make errors, but having a medical error clearly leads to distress and burnout. So we're all going to make mistakes. It is inevitable. We are human and we're not perfect. So we need to learn from those mistakes, and I have tried to do that with every error that I've made. But we also need to support one another, and we need to be able to forgive ourselves as easily as we forgive our peers when they come to us. Having a malpractice suit magnifies everything. I was at a dinner party years ago sitting across this table from a lawyer, and I was saying, how devastating it is for a physician to be in a malpractice suit, and that lawyer said, well, I don't know why you'd think that. That's just the way the system works. So lawyers don't think the same way that we do. Peer support programs are really, really important, especially after adverse events, to renew the compassion. And studies have shown that support by peers is way, way better than being sent to an employee assistance program or having a mental health referral. So we are our best support. We have been lucky to have Dr. Claudia Finkelstein as our Director of Faculty Wellness and Peer Support. She is leaving next month for a new position. I want to thank her, and we will miss her very, very much. So this 80% will take a lot of work. It's work from our institutions and our leaders. It's work from our professional societies, the Patients Before Paperwork Initiative, the National Academy of Medicine has a wellness toolbox, the AMA initiatives. It will require regulation and policy changes, and it will require more work. But I want to focus on that 20%. So I have shamelessly stolen this three-step program, although I've modified it, from an article by Balch and Schoenfeld. And so the 3 steps then are identifying and balancing personal and professional goals, identifying stressors, and nurturing personal wellness strategies. So the first thing to think about are your personal and professional goals. And you might think about, why did I choose to become a physician? Why did I choose to go into my field? What do I like most about my job? And think about, what do I most want to have accomplished at the end of my career? So my Stephen Covey experience is, I was reading his book, and at the end it said to write your obituary. I know this sounds really, really morbid, but I did write my obituary, and I found it really helpful in terms of how I was combining my work and my family. And I can tell you, meeting RVU targets was not in there. A couple of websites that you can look to go for goals and values are on this slide. The other thing is then integrating work and everything else. And do you live the way as your greatest priority, and where are you the most irreplaceable? You can think of the spheres of your life as glass or rubber balls. So your health and your family are glass balls. If you drop them, they will break. Work is a rubber ball. Drop it, it bounces. So then, enhancing work that is personally meaningful to you. Remember that 20% Mayo Clinic, where they spend at least 20% of their time on what they like the most. Take the time to reflect on what you like and talk with your colleagues, because you may be able to make some changes there. And then nurturing personal wellness strategies. Obviously, sleeping, eating, we know that. Relationships, vacations, taking time for personal reflection. For surgeons, seeing their primary care doctor actually decrease their burnout rate. And as we know, on the airplane, you put your own oxygen mask on first before you assist others. So, I have given a variation of this talk a number of times over the last 3 years, and more people have come back to me and said, this was the best advice that I had given, and that was to take a day off after you travel, whether it's work or vacation. People don't need to know that you're back. And identify emergency backup systems, schedule time for yourself, and decide what time is sacred and honor that. This is actually pretty much a good description of me. The degree to which you do not believe you have time to spend even 10 minutes sitting quietly is the degree to which you desperately need to spend 10 minutes sitting quietly. This pretty much describes me. Last year, we heard from Dr. Chopra that we should all meditate every day. And he said, if you don't have time to meditate, then you have to meditate twice a day. So mindfulness-based stress reduction, this is deliberately paying full attention to what is happening around you and within you, awareness with no judgment or criticism. It can include narrative writing and meditation. I took the mindfulness workshop that's offered with the School of Medicine and the GME, and I found it helpful but very difficult. I will confess I did not go to the all-day silent retreat on Sunday. One of my sons was leaving for Asia for a number of months. It was a beautiful day, even though it was March. And I didn't go. They said I would surely want to reschedule that time at some time in the future. That was 6 years ago, and I have not done so. I have found narrative writing helpful. If I've had a problem with a patient or a bad outcome or something that has affected me emotionally, I have written that down, and then I have put it in a drawer and then taken it out and read it aloud to myself. And that has been very, very helpful. I haven't felt the need to publish these things, but that piece of mindfulness has been quite helpful. And mindfulness training in primary care, physicians found that they were less burned out and their patients were happier too. So focusing your strategy, this requires daily attention. I realize how much I'm using that 80-20% rule, right? So the 80% rule, that 80% of life is just showing up. We've all heard about that. But the other two 80% advices that I want to give you are, if you're in an administrative role, you're going to spend 80% of your time with the 20% of your most difficult employees. It should be the other way around. And then finally, Dr. Julie Freischlag gave a surgery lecture here when she was chairman of surgery at Johns Hopkins, the first woman chair of surgery at Johns Hopkins. And in her lecture, she said she wouldn't even have been chosen as a resident at Johns Hopkins in surgery, but she ended up being the chair there. She gave a lecture here, and she gave a quote saying that if you like your job 80% of the time, that's the maximum that it can be. I found that so helpful. I've also gotten feedback other people have as well, because we're always going for 100%. But we can get to 80%. And so I found that was very, very helpful. I think that we're lucky that we do have meaning in our work. I think senior physicians, we're lucky that we mentor our junior faculty. That will be one of our legacies, and that will help us on the horrible day that we all have. A pediatrician at Children's has a Why I Do This file on his computer, and it has in there patients that have been meaningful to him. And on a bad day, he goes to that file, and that helps him feel better about things. I recently learned that we are all wired to negativity. I thought that it was just me, but the negative screams at you, but the positive only whispers. And so we can look at things as either heartbreaking or heartwarming. So this reading about that led me to the Duke Patient Safety website, to a YouTube video by Brian Sexton that I would encourage you all to take a look at. And it's the idea of having a gratitude journal where every day you write down 3 good things that happened and why they were good. They're calling it bite-sized resilience. It's based on the work of Martin Seligman, a professor at the University of Pennsylvania. So they recommend that you do this at bedtime. They say this is actually the best time to do anything that you want to remember. So if you're studying for your boards, it sounds like you have to do that at bedtime as well. You should do it for at least 2 weeks. And in one study, it was found to be as good as an antidepressant. And so I got a little journal and I started to do that. And it's an easy thing to do, and it was really quite helpful. And Dr. Seligman's books I also recommend as well. So try one thing, especially taking a day off after being on call or being away. Try to schedule at least one vacation that's 2 full weeks in a row. Writing a thank you letter, talking with your colleagues, a journal, or mindfulness. And a shout out to the senior faculty. We have to protect our junior faculty because they're at a higher rate of burnout than we are, because we've all survived it if we had it. And that junior faculty mentoring is an enduring legacy. The thing I hear over and over from mentor award winners is that this is the thing that has been the most meaningful to them in their academic careers. We have to get rid of the culture of endurance that we all grew up in. And there also should be no shame in admitting to burnout, and we should not be ashamed to admit our medical errors. I think that we can survive and we can thrive. We can recharge our batteries and align work and everything else. And I want to end with a quote by Viktor Frankl, a concentration camp survivor who wrote an excellent, wonderful book called Man's Search for Meaning, that those who have a why to live can bear almost any how. So I want to thank the university, the school, the Department of Medicine, the GI division, and especially my family, Dr. Jim Bushyhead, and my 3 sons, Jesse, Joe, and Daniel, to whom I am so grateful for their support and their love. Thank you very much.